actually answer some questions and try not to be long-winded about them. So we would like to ask me something that they haven't had a chance to ask their physician.
I got a question about pain.
Okay. So can't give you specific advice if you're not my patient, but let me talk in general. So there is levaquin belongs to a group of drugs that are called the fluoroquinolones, and they actually can damage the peripheral nerves. Okay, so you can have a neuropathy, peripheral nerve problem, again, MS, central nervous system, brain, and spinal cord, versus peripheral nerves coming out of the spinal cord, going down your arm, going down your leg, going across your trunk. So it is possible that those drugs can get damaged from those kinds of drugs. So those are typically, so the way you know you have a peripheral nerve pain, if you don't have MS, it's that you have burning, stinging, stabbing, burning pain, which is kind of like the same description of pain that you have if you have MS. So I think it's always impossible in an MS patient to know for sure is it a peripheral problem or central. Although sometimes the tests we have, sometimes the tests we have for the peripheral nerves can actually tell if there's a problem, but many times because the nerve fibers are these small little tiny fibers, those tests can be done. So the question is, what are the options? So typically first-line options these days are the Cymbalta, the Lyrica. When those fail in my practice, I go next to the sodium channel blockers. That's the carbamazepine or Tegretol that I told you about, but there's some with fewer side effects like trileptal. There's some with desirable side effects like weight loss in some patients. So zonisamide, when that fails, then there's drugs like Keppra. When that fails, depending upon where the pain's at, there are something called a neurostimulator, which you can implant in the spinal cord that kind of turns off the pain as it enters the spinal cord. One problem for that in MS patients is if you get a neurostimulator, you can never have an MRI again. And in MS, that may be something that you feel like you can't live without. Although keep in mind, people did take care of patients in MS in the days before we had MRI. But certainly with relapsing remitting disease, that would be very hard these days to not be able to do an MRI. Baclofen pump, I should mention, is compatible with getting MRIs done. So there are other pills to choose from. Then sometimes the interventional guys can do specific blocks for specific regions, TENS unit approaches and stuff like that. So there are some options. And there are physiatrists who specialize in pain. There's other doctors as well. Did I cover the question?
So what's the next step I should do? What kind of doctor should I see?
So if you've worked with your MS doctor and he says, I don't know what else to do, then you should ask him for a referral of who he would recommend you see, because he knows your case better than I can know your case from your question. You could see an anesthesia pain specialist, you could see a neurologist who does pain, there's physiatrists who do pain, so there's a whole host of different physicians who do pain. Yes, ma'am? Okay, so numbness without pain. So numbness is sort of a negative symptom. You lack something. Okay? Unfortunately, we have nothing right now that improves numbness. So one of the areas of active research, which was not being researched 15 years ago, or at least it never made any of the meetings I went to, are things that have to do with repair in MS. So, everything up till now has been working on stop the destruction, stop the attacks, keep things where they are, but only recently have people started to look at the opposite. How do we fix things that have already been damaged? So I think from a research perspective, people are starting to look at that stuff, but I don't know anything that's nearby, so we don't have anything, unfortunately, to treat numbness. Fortunately, unless the numbness is in that very specific area that interferes with something you do, like, you need fine hand control when you're not looking, you're numbing your hands, or I had a dental hygienist in my practice who fortunately recovered enough to go back to practice, but she says when you scrape the teeth, you have to be able to feel that. Many times numbness is there, but is not particularly disabling. But, for her, she was very close to, I can never go back to my profession. Fortunately, she recovered so she could. It's not because I did anything great for her. Okay, you know, she got her steroids and we waited, we prayed together, and that's about all that we could do. So right now we don't have anything for that, unfortunately.
You were talking about the baclofen pump before, and my question is about someone that I know who had a stroke, who has a left side not working,
right,
and is suffering from severe leg spasms. Is that something that a stroke patient can also benefit from?
Yeah, so it's a little trickier, right? So half is fine, half is bad. How does the drug know which side to go to? The answer is the drug goes to both, right? But fortunately, because of the miracle of feedback loops, when things are working right, is they can actually accommodate quite a lot of outside interference before it becomes an issue. So while the response, believe it or not, is probably better in somebody who has a transverse myelitis and a unilateral stroke, it is certainly a very useful drug and is widely used in strokes. Now, if it's just a leg, people do consider Botox, but the problem with the whole leg is you need 800 or 900 units, which is starting to get up. Number one is a cost issue because Botox from the company costs $600 a vial, give or take, and lasts for 3 or 4 months. The other issue has to do with safety. So certainly Botox up to 300 or 400 units is completely safe, but you start getting 800 to 900, I get very nervous, for lack of a better word. So I actually send those people to PM&R folks who do that all the time because I have a problem with both the financial cost as well as the safety issues when you use that much of a toxin. But the answer is, yeah, and the way to do it is to ask the doctor for baclofen test dose. So to do baclofen test dose, you just do what you normally do. You go to the doctor, they inject some baclofen in your spine, and you see how you feel for the next few hours. And if you feel better, it means you do it. Because over time, you'll adjust the medicine up to get to an optimal response. And we're just giving you a little bit. But if a little bit makes you better, then by all means, that's what you ought to do.
Thank you.
Sure.